We encourage everyone to participate in this discussion. If you have any questions, please raise your hands and wait until you have been acknowledged by one of us. If you require assistance with anything, please feel free to approach one of us again or one of the volunteers around you. We hope to have a good business session today. Please keep in mind the time law nature of this forum.
First of all, I will be going through the list of speakers in the order of the presentation. Shreya Kumar, Tamil S, Teresa Soni, Kartika R, Arjun Pal, Vaishnavi M, Vineet Reddy, Sanjana Kumar, Ajita Genis, Zahid Said Iqbal, Mohammed Kaif, Bharat Nayak.
We will now be starting with the presentations. I just called on presenter number 1, Shreya Kumar. Her study looks at the effects of prenatal antibiotic exposure in young people.
Time starts now.
Good afternoon. I will be presenting my project titled Effect of Maternal Antibiotics on Preterm Neonatal Outcomes, a retrospective cohort study done under the Department of Neonatology and Department of Obstetrics and Gynecology. Let's start with talking about the microbiome, which starts developing in an infant's early life and is influenced by several factors, one of which is perinatal exposure to antibiotics. These antibiotics could be administered either directly to the neonate or to the mother, which then reaches the baby through placental transfer or lactation. When given to mothers, they could also alter the maternal gut and vaginal microbiota, which then influences the infant's microbiome. This establishment of the gut microbiome in an infant's early life contributes to the immune and metabolic homeostasis of the individual. The derangement of this entire process or dysbiosis has been linked to several neonatal complications, including late-onset sepsis, necrotizing enterocolitis, and death. Our primary objective was to examine the impact of prenatal exposure to maternal antibiotics on the composite outcome of necrotizing enterocolitis, sepsis, or death in preterm neonates. Secondary objective was to examine the impact of this exposure on the individual components of the primary outcome, which are necrotizing enterocolitis, sepsis, and death, on the duration of hospital stay in preterm neonates, and to describe the patterns of antibiotic usage in mothers before delivery. We conducted a retrospective cohort study where we included 200 intramural births from December 2022 to February 2023 with a gestational age between 26 and 36 plus 6 weeks, and we excluded infants with any major congenital anomalies. These eligible neonates were enrolled into our study, and their data was obtained from medical records, and then they were followed up through these records till discharge or death or 28 days postpartum, whichever was earlier. They were further divided into two groups, exposed and unexposed, based on the exposure. This exposure is defined as mothers receiving any systemic antimicrobial treatment within 1 week prior to delivery during their birth hospitalization, other than the one dose that they might receive as surgical prophylaxis in case of cesarean section. The composite adverse neonatal outcome is defined as the occurrence of either death or necrotizing enterocolitis or sepsis within this follow-up period of discharge or death or 28 days postpartum. The dichotomous outcomes, including the primary outcome, were compared using the chi-square test, and the duration of hospital stay was compared using Mann-Whitney test. In addition, we constructed a multivariable model to adjust for the key confounding factors, including gestational age, sex, and antenatal steroids, which were included based on existing literature review. And then the adjusted odds ratio for the primary outcome was reported. So from all the eligible neonates that we screened, we obtained our cohort of 200 neonates, which were divided into 77 exposed and 123 unexposed. Among the exposed neonates, 11 developed the composite outcome, 1 developed necrotizing enterocolitis, 8 developed sepsis, and 8 neonates died. And from the 123 unexposed, we saw 29 cases of the composite outcome, 2 cases of necrotizing enterocolitis, 16 of sepsis, and 19 deaths. This table compares the baseline characteristics of neonates and mothers between the two groups. This is a busy slide, so I would like to highlight that on an average, the gestational age at birth for the exposed neonates is about 5 days less as compared to the unexposed ones. Also, the exposed neonates are associated with a higher frequency of antenatal steroid intake in their mothers and a lower frequency of cesarean section as a mode of delivery. The other characteristics are similar between the two groups. On a univariable analysis for the neonatal outcomes, we saw that the composite outcomes and its components, necrotizing enterocolitis, sepsis, and death, and the median duration of hospital stay was comparable between the two groups. When we constructed the logistic regression model, where the exposure was adjusted for gestational age, male sex, and antenatal steroid intake, we saw that maternal antibiotic exposure is significantly associated with a decrease in the odds of the composite outcome. As expected, a higher gestational age is also associated with a decrease in the odds of the outcome. Male sex and antenatal steroid intake are not significant predictors. This slide describes the pattern of antibiotic usage among our 146 mothers of 146 neonates, where the majority of the antibiotic courses administered is constituted by ceftriaxone and metronidazole given for the purpose of surgical prophylaxis in case of cesarean section. The second commonest indication being preterm premature rupture of membranes. Other common antibiotics include ampicillin and erythromycin. So, contrary to our hypothesis, we saw that maternal antibiotic exposure is associated with a decrease in the odds of the adverse neonatal outcome after adjusting for key confounding factors, which suggests an overall protective effect of these antibiotics on the neonates. The higher prevalence of antibiotic use among our mothers could have been due to the inclusion of only preterm neonates in our study, as well as inclusion of high-risk pregnancies, as our institute is a tertiary referral center. These antibiotics were indicated for maternal conditions such as preterm premature rupture of membranes and chorioamnionitis, which suggests that adequate therapeutic use of antibiotics for maternal conditions could have a protective effect on the neonates. These maternal conditions which were seen in the exposed group can also explain the lower gestational age of the neonates in this group and thus a higher antenatal steroid intake in their mothers. Our study primarily aimed to generate preliminary data to inform further prospective studies, and our study population represents neonates from a tertiary referral facility and provides data on South Indian population, thus addressing the paucity of data in this population. The limitations of our study include a geographically limited population, a small sample size, and retrospective data. We also did not record exposure to antibiotics during lactation, and we did not assess the association of exposure with dysbiosis and long-term clinical outcomes. So our results say that when antibiotics are prescribed to mothers, when required for certain medical conditions, could have an overall protective effect on the neonatal outcomes after adjusting for the key confounding factors. The duration of hospital stay is not affected by maternal antibiotic exposure. Since our study described the pattern of antibiotic usage among mothers and its association with adverse outcomes of the neonates, it could help inform clinicians and improve the clinical practice. I would like to end by highlighting the need for further prospective studies that study the association between this maternal antibiotic exposure and changes in the microbiome and resistance patterns, as well as short-term and possible long-term clinical outcomes, including atopy, asthma, or obesity. These are my references. Thank you.
Any questions? Any questions from the students? Anyone? The whole purpose of this is lost if people are not going to ask questions. Please ask questions. Anybody who asks a question will get a chocolate. Okay. Seriously. I'm serious. Okay. Let me ask you a question.
Yes.
If your friend won't confuse. Why did you adjust for male sex of the baby?
So based on existing literature review and for biological plausibility, since now numerous studies have found that male and female infants have a different set of microbiome which could influence the outcomes that we're talking about.
See, microbiome, I don't think we should bring in. We should just
Okay.
talk about the mortality rate or complication rate in boys and girls.
Yes.
Welcome next study. I have two dogs. Yours is basically a taken Peter babies.
Yes, ma'am.
So it's not that all Peter babies receive, I mean, Peter mothers receive antibiotics.
No, ma'am.
So we have included the PRON, something which is not clear. Because we may have Peter patients for various reasons. In those patients, antibiotics given are not therapeutic use. Have you taken those where we give only prophylactic antibiotics or when taken only therapeutic? That is not clear from this.
Ma'am, out of the 200 neonates, 146 mothers received antibiotics, including the surgical prophylaxis, and 77 excluding them, which means the difference is the mothers who received only surgical prophylaxis.
Yeah, so that could have made a difference giving therapeutic antibiotics and prophylactic antibiotics. You will see the difference.
Ma'am, actually,
Outcome of the
we did not include the surgical prophylaxis since it's administered very close to delivery, and our hypothesis was testing effect on the microbiome, so we did not include it, since it is less likely to affect the microbiome and thus the outcome.
12% for the dog. You said that the antibiotics given to the mothers,
Yes, sir.
and we have seen the neonates also.
Yes.
So in the neonates, what are the organisms isolated?
So we did not record the data of the organisms isolated. We just recorded whether sepsis was present.
In definition perspective.
The culture positive blood or CSF samples. So we saw Klebsiella and no, ma'am, for neonate, the sepsis was defined as culture positive blood or CSF sample. We saw several organisms. We did not record data, sir, so I am not sure about which were the predominant organisms.
Because I would like to know whether any antibiotics correlate with sensitivity pattern of organisms.
Yes.
So after completing the study, do you think we have to use the term association, not causation? So do you think maternal antibiotics are good or bad?
So I would say that maternal antibiotics, if required for infectious conditions, are good, and we can see that they, according to the odds ratio, outcomes are 75% less likely in the exposed group. So if they are, in our institute, we give antibiotics to treat infectious conditions when required. So I think in that case, it will be good, but we need further studies with a larger sample size, with maybe different institutes where the adequacy for treatment is not sufficient.
What if I use more antibiotics?
So I think adequate treatment is what would lead to good outcome. And if we can have larger studies with the bigger sample size, we can have a clear access. Thank you.
Thank you so much.
Despite a decade-long effort to improve menstrual hygiene in low-income countries and period poverty versus due to the financial and environmental burdens of disposable pads, interest is now shifting towards sustainable solutions like menstrual cups. So the next paper will be presented by Kavita C regarding the same topic. The time starts now.
Good afternoon to everybody. I'm Tamil Arasi. My ID number is UG4. My topic is title of the project is Assess the Usage Pattern of Menstrual Cup and its Determinants Among Young Women in Health Profession in Tertiary Hospital in Puducherry. The introduction. So the women plays a significant role in family as well as in society. So it is very necessary to give importance to the women's health as well as their menstrual hygiene. So we know that menstrual cup is composed of a flexible silicone. So it can be reusable menstrual hygiene device. So it is inserted into the vagina to collect the menstrual bleed during the menstruation. Unlike in the tampons and sanitary napkins, it's need not to be discarded. So it is eco-friendly in aspects and also provides us a leak-proof aspects also, and it also helps the women to maintain a hassle-free menstrual hygiene. So it relieves the stress of the women. So here they are improving the quality of the life. So menstrual cups are better alternatives as compared to the any other sanitary products. So it does the usage among the women or the girls is limited due to the lack of the popularity. So the primary objectives are to find out the prevalence of menstrual cup use among the young women and to identify the determinants of menstrual cup use among the young women in health profession. The methodology used are quantitative research approach with a cross-sectional analytical study design. The setting was about in JIPMER, and the participants were young women in various health profession. And the inclusion criteria were women belonging to 18 to 24 years and who are able to read and write English. The sample size calculation was calculated using a single proportion formula, where a previous study was conducted in Bangalore, where 20% of prevalence was present over menstrual cup users. So the sample size calculated here is 369 at 5% of level of significance and 5% absolute precision. So the design effect is 1.5 for cluster sampling. For selecting the participant from the various groups in JIPMER like nursing, medical, and allied health science, we used cluster sampling. The data was collected using a self-administrative questionnaire where it was made by self-made and it was validated by experts. So there are two parts in the questionnaire where the section A, that is part A, has two sections, A and B, where section A includes the socio-demographic profile such as age, course of study, year of study, religion, marital status, residency, and source of information. And section B include the menstrual profile, which indicates the regularity of the menstrual cycle, duration of menstrual cycle, gynecological issue, and type of sanitary product they use. And part 2 included the current menstrual users and the previous users and who have never used. So there are a set of 10 questions in each tabular, where 6 was about the opinion about the menstrual cups, and the 4 were reminding on the statement the probable reason for their use and non-use of menstrual cup. The data were analyzed using SBS version 21, and all statistical analysis was carried out at the 5% level of significance. The categorical variables such as residence, regularity of menstrual cycle, menstrual flow, gynecological issues, and pattern of menstrual cup, etc. was expressed in frequency and percentage, and the continuous variable was expressed in mean and standard deviation. Association between the categorical variables of socio-demographical and menstrual personal factors of usage of menstrual cup was tested using a chi-square test. Coming to the result, this table describes the distribution of young women on their socio-demographic profile. As it is evident that the source of information about menstrual cup is through media, that is 68.7%, whereas followed by the friends, that peer influence on menstrual cup is about 24.6%. The mean age of young women in the present state is 20 years. This table describes the distribution of young women based on their menstrual profile. So most of the women have a regular menstrual cycle, that is 86.8%, and no significant gynecological issues. And the majority of women's uses in sanitary napkin as their sanitary product, that is 92.2%. The mean duration of menstrual cycle was 5 days. This figure depicts that only 29 out of 370 young women were using menstrual cup, and the remaining 333, that is who have never used menstrual cup, and the 8 who have not presently using menstrual cup who have been used before. Among the 29 menstrual cup users, nearly 90% of young women used it because it is comfortable and non-allergic, convenient during travel, and then enable free movement. While below 80% of them used it because it is eco-friendly, affordable, leakage-proof, and better for maintaining hygiene. About 75.6% use menstrual cup as it is easily available, and 51.7% has used to insert. Out of 370 young women, only 8 were not presently using due to various reasons such as difficulty to insert, pain during insertion, and then inappropriate size of menstrual cup. And then they were reporting that very few reported it is costly, and 1 in 8 has reported it was affected by infection and allergy. Among 333, that is 90% of young women who had never used a menstrual cup reported that nearly 70% of young women thought menstrual cup insertion would be difficult and uncomfortable. And 43.5% were doubtful about their availability of appropriate menstrual cup size. And 52.3% fear it would cause pain and it would lead to infection and allergy injury was below 30%. And only 19% felt it is costly and it is not easily available. The association between the variable of socio-demographic, menstrual, and personal factors with the pattern of menstrual cup use, where statistically significant association is only with the year of study. None other thing was significant. The discussion. So the current study showed that only 29 out of 370 young women in health profession use a menstrual cup. This finding is much higher than the study which is conducted in Karnataka in 2020, where health profession uses where 2.6% of women used menstrual cup. Well, the study conducted in Kerala in 2022 was 350 females in the general population found higher proportion, that is 15.1% of them using menstrual cup. About 80% of user in the study is used it because of its eco-friendly aspects and affordable leakage proof and better for maintaining menstrual hygiene. A group of women studied in Mumbai has reported the same aspects, that it is affordable and it also reduction in the waste compared to the sanitary pads and their preference for their menstrual cup. Though the source of information was greatly seen through media, but peer influence seems to be the important contributing factor for the usage of menstrual cup. Disparity in the menstrual cup usage and its determinants among young women can be attributed to several factors such as study contest and the size of the population study, socio-demographic characteristics, and the greater accessibility and acceptance of sanitary pads when compared to the menstrual cup among young women. Conclusion, the women belongs to the health profession had awareness about menstrual cup, though were not using because of the pre-assumed thought that it would feel difficult in insertion, pain during insertion. So this emphasized the need for awareness and frequent reinforcement regarding better menstrual hygiene practice with the help of menstrual cup. These awareness programs can be implemented or conducted through adolescent clinics in the primary health centers and hospitals. These are my reference.
Do we have any questions?
There's a question.
Yeah. Actually, when we were supposed to say, we assessed the users, there were very few said that it could cause pain. Many of them, the users were not reporting it was painful.
Is it because of menstrual cups or is it because they don't know the
Proper usage of menstrual cup will also be a determinant for pain that may cause pain. Infection, toxic shock syndrome can occur. Improper use of menstrual cup can lead to toxic shock syndrome also. There were reports.
Question?
on the methodology, I just want you to explain how important is sample size calculation for a study like this, where you're looking at relationship between different variables in a single group.
In cluster sampling.
No, how important is it to make an elaborate? For example, you've taken a stand, a common sense stand, say, I'm going to ask 100 people these questions versus doing a rigorous calculation like this. How much do you think your results would have differed?
I think
Actually-
the question is unfair to her. But, for her, the question is unfair, okay, but, so this is a question. If you're wanting to get a good idea, I think if you ask 50 people, you get a good idea, and that is fine. But when you do a formal study, as she was expected to do, she will have to do that. And so the question is, you said it was related to the year.
Yes,
When
sir.
you looked at, but it was maximum in the third year and then again very low in the fourth year.
Yes.
So it was not related to the year. It was just that in one batch, girls started using it and this it spread, right?
Here it indicates that third year students were using it as
But
they
does
were.
that mean that next year, third year, will be using it that time, right?
Yeah, that is
Okay,
correct.
so it's just that it is a whatever. Okay, you get my point.
I can correlate that the people using in the third year were higher rate of influencers. So among
Yeah,
their
whatever,
friends.
yeah. So somebody tried and then you're done.
Thank you.
For request everyone to your attention to the time. You only have 8 minutes. If you exceed that time, you will have less than 2%. Please bear in mind. Next, I call is subject number 3, Teresa Soni. Her work looks at different pathological cardiotopographic recordings and their potential utility in predicting fetal outcomes. Over to you.
Good afternoon. I'm here to present my paper entitled Analysis of Pathological Cardiotocogram Patterns and Feto-Maternal Outcomes Among Laboring Women Beyond 32 Weeks of Gestation, a Prospective Observational Study. Cardiotocography is a method of intrapartum fetal surveillance that helps in the early recognition of fetal hypoxia. According to the FIGO classification system, a CTG can be classified as normal, suspicious, or pathological. A pathological tracing indicates a high probability of fetal hypoxia, necessitating expedition of delivery. However, CTG has been found to have a low positive predictive value, and this results in a higher incidence of unnecessary cesarean sections with no significant differences in neonatal outcomes. This necessitates a detailed clinical characterization of pathological CTG tracing patterns and its various phenotypes. Our primary objective was to assess maternal and neonatal outcomes among women with pathological CTG tracing during delivery. We had two secondary objectives. One, to identify the adverse outcomes associated with different pathological CTG tracing patterns. And two, to analyze obstetric and anesthetic decision-making in each pathological CTG tracing pattern. Coming to the methodology, this was a prospective case record-based observational study with data collected over a period of 3 months. We included women carrying a singleton pregnancy, delivering at more than 32 weeks of gestation, with fetus in the cephalic presentation, and having a pathological CTG tracing during delivery. We excluded cases of lethal fetal congenital anomalies and planned elective cesarean sections. These were the outcome measures for this study. The primary outcome was the 5-minute ABGAR score, while the secondary outcomes included mode of delivery, mode of anesthesia, indicators of neonatal morbidity, neonatal mortality, and NICU admission. The sampling technique employed was the convenient sampling technique. Around 100 to 120 cases of pathological CTG were expected per month, giving us an expected sample size of 300 over the limited study duration of 3 months. This was the study procedure employed in the study. A total of 3,002 deliveries were conducted in our institute during the study period. From these, we identified deliveries with the pathological CTG from the birth register in the delivery suite. Study participants were then recruited according to the inclusion and exclusion criteria, giving us a total of 271 study participants. We then collected relevant data, including maternal baseline characteristics, details of labor, maternal and neonatal outcomes, and CTG parameters from the case records of recruited women. The data was then analyzed. Data was collected using REDCap and exported to Stata 14 for statistical analysis. Associations between pathological CTG tracing and corresponding maternal and neonatal outcomes were analyzed using the Pearson's chi-square test or Fisher's exact test. A multivariable logistic regression analysis was also performed to assess the risk of NICU admission. A p-value less than 0.05 was considered significant. Informed consent was obtained from all participants before data was collected from their case records. Coming to the results, This table represents the demographic and clinical characteristics of our study participants. The mean age of our study participants was found to be 26.3 years. The majority of the study participants were found to be primary gravida, 62%. The most common risk factor was found to be fetal growth restriction, and this was seen in roughly a third of the study participants. The second most common risk factor was found to be oligohydramnios, and this was seen in about a quarter of the study participants. Other common risk factors included diabetes mellitus, postdated pregnancy, and previous cesarean section. This table represents the neonatal outcomes of our study participants. The vast majority, that's 89% of our neonates, were delivered at term. The birth weight was found to be less than the third centile in about a third of our study participants. The primary outcome measure, that's 5-minute Apgar score, was less than 7 in only 2.5% or 7 of the neonates. 77 neonates required NICU admission, and 15% required significant resuscitation at birth. We assessed 3 complications: respiratory distress, which was seen in roughly 36% of our neonates, hypoxic ischemic encephalopathy, which was seen in 5 neonates, and sepsis, which was seen in 10 neonates. Of the 5 neonates who developed HIE, 1 developed severe HIE and succumbed after 4 days of NICU admission. This represents the maternal outcomes of our study participants. 36% of our parturients underwent delivery by instrumentation, while 64% underwent delivery by cesarean section. Of these, spinal anesthesia was administered in 5 out of 6 cases. Now, from our 271 study participants, we identified 11 different phenotypes of pathological CTG tracings. Of these, the most common pattern was found to be repetitive late decelerations, and this was seen in 24.7% of our study participants. The second most common pattern was found to be the combination of reduced variability with repetitive variable decelerations, and this was seen in 24.4% of the study participants. Other common patterns included the reduced variability, prolonged decelerations, and the combination of reduced variability with repetitive late decelerations. Subsequently, associations were analyzed between the various phenotypes and our outcome measures. We found significant associations with the secondary outcome of mode of delivery. Significant associations were not found with the primary outcome or the remaining secondary outcomes. This graph represents the association with the 5-minute Apgar score, with mode of delivery, and with NICU admission. In addition, a multivariable regression analysis was also performed to assess the risk of NICU admission. It was found that the pattern of tachycardia with reduced variability was associated with a 5 times higher risk of NICU admission with a p-value of 0.018. In addition, the patterns tachycardia with late deceleration and the combination of repetitive late decelerations, prolonged decelerations, and reduced variability was associated with moderately increased odds of NICU admission. However, this was not significant. Coming to the strengths and limitations of the study. The strength of the study lies in its prospective study design, which helped us analyze and evaluate the outcome measures thoroughly. The most obvious limitation of the study, on the other hand, is its small sample size. In addition, the pathological tracings which may have occurred in the earlier phases of labor and which may have resolved with intrauterine resuscitation were not studied. Moreover, the duration of the individual CTG tracings were not taken into account. CTG tracings were also interpreted by a single physician, and the physician differed between cases, raising concerns of inter-observer bias. To conclude, significant associations were found between the various pathological CTG patterns and mode of delivery. However, the various patterns did not significantly affect neonatal outcomes. We conclude that any pattern of pathological CTG tracing should be considered for appropriate emergent delivery, giving other risk factors due consideration. Nonetheless, the odds of NICU admission were significantly higher in women with tachycardia and reduced variability. This warrants the conduction of future larger studies. These were my references, and this is the FIGO classification of CTG. Thank you.
Do you have any questions? Mr.
In the criteria, one of them was single pregnancy, like, how will that really?
We wanted to avoid inclusion of multiple pregnancies as this would have been a confounding factor and independently affected the CTG tracing patterns. This is why we included only singleton pregnancies. No, so here we were trying to assess if there is any association between the various phenotypes of a pathological CTG. We were not comparing a pathological CTG with non-pathological types. So we did not require a control group. Yes. This might have contributed to making the study better, but it was not required for this particular study.
Nice presentation, but already we know pathological CTG, the risk of severe initial spin. What is new about this one?
Ma'am, we wanted to make a detailed analysis of exactly how a pathological CTG presents. For example,
I understand all the 11
yes.
parameters you had. This is already described.
Actually, ma'am, the number of studies describing the different phenotypes of pathological CTG were found to be slightly lacking. There are a number of studies describing pathological CTGs overall, but the number of studies in which the different phenotypes of a pathological CTG were described were found to be lacking.
Maybe many more, but I have just to know. You said CTG was interpreted by a single observer. How do you know about that? Because this is from the case report.
Yes.
What is recorded in the case is always not good. They won't have the informed senior and everyone interprets, right?
Yes.
So that is not a thing which you can write from your case report. It's not correct. Why do you think tachycardia with reduced variability alone had a higher risk of eco admissions, whereas reduced variability and all those things are not that high? That's what you said among all the patients, those with tachycardia and reduced variability had higher risk for eco admission. What was the reason in those patients?
The exact reasons for increased risk of admission in those cases cannot be concluded directly from the study. Tachycardia is mostly seen in cases of maternal pyrexia, which occurs in case of choriamnitis. So the presence of these additional risk factors,
The numbers may not have been that many.
there were not that many, ma'am. The small sample size is in fact a limitation of this study.
Directly, you cannot say that this is eco admission.
Yes.
Like to answer the question without tachycardia. So the eco slide you showed some picture, right? Eco admissions. I could see some boxes.
Yes.
So why are some boxes large and why are some small? Thank you.
Thank you.
Call upon next presenter, UG8, Kartika R. Study looks at the utility of immediate Mata nerve conduction studies in detecting diabetic neuropathy, one of the most common complications seen in diabetes.
Good afternoon, everyone. This is Kartika from second year BSc Neurotechnology. I'm here to present a project that we have done under GJS class on the title Assessment of Medial Plantar Nerve Sensory Convection and its relationship with severity of diabetic peripheral neuropathy, a cross-sectional study in our Department of Neurology. So diabetic peripheral neuropathy develops in the lifetime of a patient with diabetes. There's a chance of developing 50%, there's a 50% chance of developing diabetic peripheral neuropathy in a patient with diabetes. it can be sensory motor polyneuropathy as well as small fiber neuropathy. Small fiber neuropathy is difficult to diagnose compared to sensory motor polyneuropathy. It is most often diagnosed in its later stage, and complications include ulcers and lower limb amputation. Toronto clinical consensus criteria suggests to do nerve conduction studies for the diagnosis of distal symmetrical polyneuropathy. So the primary objective of a study is to correlate the severity of DPN measured by Toronto Clinical Neuropathy scores with the SNAP of medial plantar nerve, MPL. The secondary objectives is to correlate other parameters like onset latency, conduction velocities, and TCNA scores, and to compare the relationship between sural nerve SNAP, sensory nerve action potential with medial plantar nerve SNAP. So Alton et al. Did a similar study and got a negative correlation of minus 0.4. So we calculated to have 47 subjects and eventually included 51 subjects. It was done for a duration of 3 months. Under the inclusion criteria, we included patients of age ranging from 18 to 70 years, suspected to have DPN, referred to do NCS. Under the exclusion criteria, we have pregnant women, those with CKD, and those with lower limb amputation, edema, which make the evaluation of medial plantar nerve difficult. After obtaining consent and demographic details, we brought the patient to NCS lab, and we did the scoring, Toronto Clinical Neuropathy scoring, symptom score, sensory exam score, and reflexes were evaluated, and medial plantar nerve sensory study was done in our NCS lab. So this is the snap of medial plantar nerve that we obtained. So the primary outcome was obtained by using Pearson's correlation coefficient. The lowest MPL snap and TCNS scores were correlated. Secondary outcome, it was RSC curve was plotted and the cutoff was determined by Yoden index. Other relationships were explored using graphical methods and tabulations. Coming to the baseline characteristics, here we have averaged all of the parameters given here, except for total TCNS score, where we have found median, which is 6. The average age of our participants is 53.5. 1/3 of them were women. 10.2 is the average duration of diabetes. Fasting and postprandial blood sugar were taken, and HbA1c was also done. Few of the data we were not able to collect from all of the patients. 20 of them had no neuropathy, 18 had mild neuropathy, 8 had moderate neuropathy, and 5 had severe neuropathy symptoms. Other related comorbidities like hypertension, stroke were noted in 19 of the patients, hypertension being the predominant one. Here we plotted TCNS score against medial plantar nerve snap. So we obtained a negative correlation between TCNS and the medial plantar nerve. And conduction velocity also had negative correlation with the TCNS score. Here in this first graph, we can see that even with no neuropathy symptoms, medial plantar nerve is way more abnormal compared to sural nerve. And it follows the same trend throughout it. And in the second plot, table plot, we can see that nearly 1/3 of the table is occupied by medial plantar nerve evaluation, sural nerve SNAP evaluation, and clinical evaluation. So it's better we can include all of these three in diagnosing diabetic peripheral neuropathy. So RSC curve is also plotted, and for cutoff of less than 1.05 microvolts of amplitude, 66.67 were correctly classified to have diabetic peripheral neuropathy. So in a study, we were able to find that 82.3% of the participants had abnormal MPS studies, and this similar correlation was found in Japanese study that was done. 67.5 had abnormal MPL studies, and we got a negative correlation, as I've already mentioned, minus 0.29 with a p-value of 0.04. Alton et al. And JY et al. Also got a negative correlation. Area under the RSC curve is 0.6 with a cutoff of less than 1.05 microvolts of amplitude. This cutoff point suggests that this cutoff point is lower than the cutoff found for normal value of medial plantar nerve SNAP studies. So coming to the strengths, standard clinical neuro system was used, standard clinical neuropathy system was used, and nerve conduction parameters were also used, reasonable exclusion of other causes of peripheral neuropathy, and the limitations include in our studies small numbers, large proportion with absent MPL snap. So coming to the conclusion, medial plantar nerve has a moderate correlation with clinical evaluation and identifies more diabetic neuropathy than the evaluation of sural nerve.
There was a nice hand-drawn diagram. Did you draw that?
Yes, that one, yeah, I did. Thanks.
Yeah.
Nice,
You have a question there? It was medium plantar and now chosen for the study and not taken.
Diabetic peripheral neuropathy, especially small fiber neuropathy, is like it involves the distalmost nerves actually. It starts distally and it involves talking glove pattern, meaning it starts from the feet and it progresses towards upwards. It ascends up. So middle plantar nerve, as it is very far, I mean, it is distal, so it can be evaluated earlier. It can be evaluated, but usually we do sural nerve evaluation only in our labs. But if we include medial plantar nerve, it will be helpful in earlier diagnosis.
So then maybe we will use another nerve like plantar nerve. See, that's also one system.
Yes. That also can be assessed, but yes.
I have two questions. When do you advise, I mean, all diabetic people to, because this is a known problem, right? When should they get screened? Is there anything like screening for the neuropathy? And secondly, how do you prevent other than control of diabetes? Is there anything you can do once you find that, there is a neuropathy which is setting in? How early or how many years after diabetes setting should they be seen?
Ma'am, usually the patients that who come to our NCS lab, to our Department of Neurology has at least 10 years of diabetes. So I'm not sure, ma'am, but I think maybe 5 years, even at 5 years, they have abnormal medial plantar nerve snap. So that's what I think, ma'am.
So the results differ upon the type of footwear people wear, or there are some people who might be having lifestyle which requires them to work in fields, and there are some people who might be wearing proper footwear all of them. Does that make any difference?
No, so we did not find that.
Was there a particular reason why it shows that you can only have to serve not all the time? That way, so you said it takes 10 years, most of those high level, you were diagnosed with about, could not be given the claim
Like we wanted to include patients after 18. So that is why there's no other particular reason for that.
If you have a question.
Yeah.
How does the medial plantar nerve conduction study, sural nerve conduction studies, how do they compare with respect to technique and cause?
Sural.
It is easier to do, which is more uncomfortable to patient.
Both are similar only, sir. Both are similar actually, but we as a standard system, we only do the evaluation of sural nerve. And any nerve can be studied using NCS. nerve connection studies can be done for any nerve, but usually what we do in our lab is sural nerve study only. We don't particularly do for medial plantar nerve. For this study, we included medial plantar nerve to correlate um, how it is more important compared to sural nerve for in case of diagnosing diabetic peripheral neuropathy.
You have a question? Thank you so much.
Thank you.
Traumatic brain injury is a leading cause of death and disability in patients with trauma. The elevated craniectomy and craniotomy are the preferred surgical modalities for treatment. But effectiveness of one over the other is still a topic of debate. So now here we have Dr. Arjun Pant with his paper.
Good afternoon. I'm Arjun Pant, an intern, and I'll be presenting my GJSTRAS project titled A Propensity-Matched Comparison of the In-Hospital Mortality of Traumatic Brain Injury Patients who have undergone decompressive craniectomy versus craniotomy. I have performed this study under the guidance of Dr. M.S. Gopalakrishnan from the Department of Neurosurgery. To introduce the topic at hand, traumatic brain injuries form a major proportion of the case inflow at the neurosurgery department at JIPMER and worldwide. And there are two common surgical procedures used to treat this: decompressive craniectomy and craniotomy. However, there is insufficient evidence on the superiority of one over the other, which has motivated this study. Propensity score matching, as you may have noticed from the title, is a component of this study and mimics randomization in observational studies to overcome selection bias. It excludes dissimilar participants from the two groups by identifying confounders and matching based on selected covariates. Crash prognostic model, which is another component of this study, was developed to estimate mortality at 14 days and death and disability at 6 months from a large RCT. This is a picture that shows the web application, the crash model, which gives us the risk of 14-day mortality in the form of a percentage. 10 variables that are specific to each patient need to be input: the country, age, GCS score, pupillary reactivity, major extracranial injury, and CT scan findings like the presence of petechial hemorrhages, obliteration of third ventricle or basal cisterns, subarachnoid bleeding, midline shift, and non-evacuated hematomas. The primary objective of the study was to compare the in-hospital mortality of decompressive craniectomy with that of craniotomy to confirm a suspicion that DC has a higher in-hospital mortality rate than craniotomy after propensity score matching for crash prognostic probabilities of 14-day mortality. Our secondary objectives were to confirm if DC has a higher mortality than craniotomy after excluding secondary DC patients and patients with primarily diffuse edema. To clarify here, secondary DC patients are those in which medical treatment has been attempted first to reduce intracranial tension, which has failed, after which a surgical approach has been adopted in the form of decompressive craniectomy. Another secondary objective was to assess if DC has a higher mortality compared to craniotomy after propensity score matching and adjusting for days in the hospital. This was a retrospective cohort study performed in the Department of Neurosurgery from June 2020 to January 2022. And all patients who have undergone DC or craniotomy for traumatic brain injury were included. And those whose case records were too incomplete to gather data, or those who underwent surgery for cranial fractures only with no hematoma evacuation, were excluded. We calculated a sample size of 264 by calculating the sample size required to find differences in two proportions of independent samples, assuming that the difference in mortality rates between the two procedures obtained from an earlier study, which incidentally was performed in our institute here in JIPMER, might actually exist. This is a picture, a screenshot of the application that was used to calculate the sample size. We obtained data from the case sheets and the CT image findings, which were then fed into the crash model to obtain a prognostic prediction of the 14-day mortality risk. This is a screenshot of the REDCap application where all the data was stored and patient data was de-identified for the security. Statistical analysis was performed using SPSS and JASP. We performed descriptive analyses and variables to summarize as mean or median or percentage. Students t-test, Mann-Whitney U-test, Fisher's exact test, or chi-square test were used as appropriate, and a p-value of less than 0.05 was considered statistically significant. The core of our study was the propensity score matching, wherein each patient from the craniotomy group was matched with patients with a similar propensity score from the DC group. In the first PSM, the two groups we chose were DC and craniotomy, and the covariate of choice was the crash score. This means that patients that had similar crash scores were compared with each other following matching. In the second PSN, the two groups were primary DC. Please note that we have excluded secondary DC and craniotomy, and the covariate of choice was the crash score. And in the third PSN, the two groups were primary DC and craniotomy. A difference here was in the covariates, where we have added a second covariate, the duration of hospital stay, in addition to the crash score. Moving on to the results. This table shows us the differences between DC and craniotomy, and we observe that patients with DC have a significantly higher rate of neither pupil being reactive, a higher rate of extracranial injuries, and a low GCS at admission, all of which are components of the crash score and are indicative of the 14-day mortality risk, which is what motivated us to include that as a covariate in this study. Similarly, on analyzing the CT scan findings, we observed that a comparison of the two groups shows more radiological injuries in the DC group, again, which is a component of the crash score, which is why we included this in the study. The results of the propensity matching showed us that when we matched the craniotomy group with the DC group, we had a sample size of 133 and 59 each, and DC was associated with a significantly greater in-hospital mortality. In the second PSM, when we excluded secondary DC patients, just to a number, bringing the sample size down to 57, we again observed that there was significantly greater in-hospital mortality in the primary DC group. In the third PSM, where we included days in hospital, we had a much reduced sample size of just 33, and there was no significant difference in in-hospital mortality rate between these two surgeries. This table shows us the differences between DC and craniotomy in the outcome parameters. Results in the outcome of the study were fairly contradictory when we performed a literature review. We saw that the rescue ADH trial, which has been performed for the past 20 years, showed no difference in mortality rates. Jehan et al. Performed a propensity matching based on demographics, admission GCS score and severity of injury, and type and size of ICH, which was slightly different from our study where we used the covariate crash score and days in hospital. They found no difference in mortality rates. Additionally, Rush et al. Compared the in-hospital mortality in the USA by propensity matching patients between these two groups. However, they noted a significantly higher difference, a significantly higher mortality rate in the DC group, which is similar to my study. To conclude, decompressive craniectomy has a higher mortality rate and has more complications than craniotomy after propensity matching for crash prognostic probabilities. Although the mortality difference becomes insignificant once we match for the duration of stay, we suspect that could be because of a reduction in sample size, which I just described a few slides before. So this means that replacing the bone flap, which is what we do in craniotomies, is potentially better than prophylactically leaving it out, which is performed in decompressive craniectomies after the evacuation of a hematoma. The strength of the study was that it was the first one to have compared the in-hospital mortality of decompressive craniectomy with craniotomy after propensity matching for a comprehensive prognostic indicator. There are several studies that have compared the two, but none of them have used a prognostic indicator as comprehensive and as widely used as the crash score. There were two limitations to this study. Firstly, propensity matching the duration of hospital stay yielded too few matches with just 33 participants in one group, with too little statistical power to find a true difference between the two surgical options. And we proposed further studies may be performed in this area. Additionally, because DC patients had a longer in-hospital stay, their mortality is counted better, and this could lead to a spuriously higher mortality rate in this group. These are my references. Thank you very much.
We have a question. Would the surgeon factors influence the outcome?
The surgeon factor would definitely influence the outcome, but surgeons commonly perform both surgeries, so it isn't possible for us to account that in a study of this sort. It isn't possible to objectively quantify surgeon outcomes through this.
Congratulations for using HIE software for your study. I have a basic question. So, despite your matching, did you account for the comorbidities in the patients because your outcome is not accurate?
Yes.
How did you match for the comorbidities?
We did not match for comorbidity, so this is a limitation of our study. There are other studies that have matched for comorbidities, but since we already had two covariates to use, we have focused on these only in our study.
You mentioned about the GCS scores. So do you use the GCS score as a board value, or do you specifically look at the pupillary scores? Because the the chart that you showed had a point on pupillary responses. What was the thing that we checked in these cases? The whole score or the pupillary score?
We had the whole score. So since the CRAF model mandates that we use the value, but the CRAF score also incorporates the pupillary reactivity. So both in a certain way were incorporated into the covariate matching.
Was there any difference between the time taken for taking up these patients for surgery? It could be that some patients were taken up for surgery earlier and some had to wait because these slots were not available.
We did assess that, sir, but I have not mentioned it in this PPT. There was no major difference in time taken to perform the surgery.
No, madam, does it make a decision making as to which procedures will be done? Would that have made a difference? Because who makes such a decision? Not being studied.
That has not been studied, ma'am, but when we choose between primary DC and craniotomy, we are only looking at patients that have a hematoma. So we have not already accounted for the presence of a raised ICP, which might mandate medical treatment and then a secondary DC, which is why I've excluded that cohort. So when we receive a patient in our setup, we have to make a choice between one of these two procedures, and very often it is up to the surgeon to make a choice, and there is no real literature that can tell us which one is the better choice between the two. So it is a very subjective choice to be made. This study has aimed to reduce that subjectivity in saying that one procedure is better than the other after propensity matching. Yeah, we had a lot of patients we noticed that only had fractures and no hematomas, and we had to exclude these because the procedure used for treating fractures is very different from that of craniotomy or decompressive craniotomy. The procedure is entirely different and is not relevant to this study. Thank you.
Experimentation, particularly in the field of forensic medicine, was determining the biological sex of an individual based on anatomical characteristics. So, Vaishnavi is here with one such study. The time starts now.
Good evening, Manager present here. I am Vaishnavi M, and I am here to present my research project titled Sexual Dimorphism with Maxillary Sinus Dimensions and Bizygomatic Distance using CT scan in the South Indian population. Sex discrimination is one of the initial and crucial steps in the identification of unknown body remains. The conventionally used bones for the sex discrimination include the skull and the pelvic bones, but they are often recovered in a fragmented or destroyed states, especially in situations like natural calamities or air crashes, which interferes with the sex discrimination using them. In such special situations, denser bones like the maxillary sinus or the zygomatic bone can be employed for determining sex. Maxillary sinus are the air spaces located in the maxillary bone that appear by the end of the second embryonic month and reach their maximum sizes by 20 years of life. They are bounded by 6 walls, which are the anterior, posterior, medial, lateral, superior, and the inferior walls. The reason why maxillary sinus was chosen in the present study is that though there had been previous literatures reporting the utility of the maxillary sinus in sex determination conducted elsewhere, similar studies with this significant sample size has not been reported in the specified population to the best of our knowledge. The objectives of the study were to correlate the sexual dimorphism with the maxillary sinus dimensions, which included the length, width, intermaxillary distance, anterolateral angle, volume, and the bizygomatic distance, to assess the degree of accuracy of the sexual dimorphism with these parameters, and to develop a formula for sexual dimorphism using binary discriminant function of the maxillary sinus dimensions and the bizygomatic distance. It was a record-based observational study, and CT head and paranasal sinus scans of individuals aged between 20 and 70 years were included in the study. All the CT scans of low quality images, scans with any fractures to the maxillary sinus or the zygomatic bone, the scans with cleft palate, or any other pathologies interfering with the morphology of the maxillary sinus or the zygomatic bone were excluded from the study. A total of 184 samples were included with equal distribution between males and females. The CT scans were retrieved from the picture archiving and communication system, and they were viewed in the axial and coronal views. Among the parameters studied, the length, width, intermaxillary distance, anterolateral angle, and the bizygomatic distance were measured in the axial view, while the coronal view was used for the measurement of the height of the maxillary sinus. The volume of the maxillary sinus is defined as half the product of length, width, and height of the maxillary sinus. The measurements were made using electronic calipers, and the data analysis was done using SPSS version 19.0. Giving a brief description about each of the parameters, this is the length of the maxillary sinus, which is defined as the distance between the anterior-most and the posterior-most point of the maxillary sinus in the axial view. The width of the maxillary sinus is the maximum distance between the medial and the lateral walls of the maxillary sinus in the axial view. And anterolateral angle is defined as the angle between the anterior and the lateral walls of the sinus in the axial view. A few other parameters are the intermaxillary distance, which is defined as the maximum distance between the medial walls of the bilateral maxillary sinus. Height of the maxillary sinus is defined as the distance between the lowest and the highest points of the maxillary sinus in the coronal view. And bizygomatic distance is the distance between the most prominent points of the zygomatic bones in the axial view. Coming to the results of our study, independent student t-test showed statistically significant differences in the mean values of length, width, height, and the volume of bilateral maxillary sinus. As we can see, the p-values are highly significant for these parameters, except for the anterolateral angle of the right maxillary sinus, which did not show a significant difference in values between the sexes. All the parameters of the left maxillary sinus, including the anterolateral angle, showed a statistically significant difference in values between males and females. While the intermaxillary distance did not show a significant difference in values between the sexes, bizygomatic distance showed a statistically significant difference between males and females with a very significant p-value. The ROC curve was assessed for cutoff, sensitivity, specificity, and the area under the curve. This table shows the discriminative ability of the various parameters to distinguish between males and females. The length and width of bilateral maxillary sinus showed a statistically significant discriminative ability to distinguish between the sexes, whereas the anterolateral angles of the right and left maxillary sinus did not show a statistically significant discriminative ability to distinguish between the sexes. Bizygomatic distance was found to have the best discriminative ability to distinguish between males and females, followed by the height of the right maxillary sinus. Intermaxillary distance also did not show a significant discriminative ability. So to summarize, except for the intermaxillary distance and the anterolateral angles of the bilateral maxillary sinus, the rest of the parameters showed a statistically significant discriminative ability to distinguish between males and females. These are the ROC curves obtained for a few of the parameters. As it is seen, the area under the curve of the ROC curve for the bizygomatic distance is much larger compared to the AUC of the anterolateral angle or the intermaxillary distance, which are very close to 0.5. This is the discrimination function proposed for predictive purposes with a sensitivity of 76.1% and specificity of 74.9%. A negative value for the discriminant function categorizes the subject as female, and the positive value categorizes the subject as male. This is the ROC curve obtained for the discriminant function with an area under the curve of 0.82. So to conclude, the various parameters of the maxillary sinus and the bizygomatic distance are found to show sexual dimorphism and can be employed in sex discrimination. Bizygomatic distance, height, and volume of bilateral maxillary sinuses are some of the parameters found to have a very high discriminative ability to distinguish between the sexes, whereas intermaxillary distance and anterolateral angle did not show a significant difference in values between males and females. These are my reference studies. Thank you.
I have one question. Do you think any observer factors might have changed the outcome? Like you could have chosen two observers and you could have found it like inter and intra-observer relationship agreement.
Yes, I understand. The first thing is these measurements are pretty easy to do. So I don't think the inter observer factors would matter much, but still it can be considered as one of the limitations of my study.
One more question is that you took 92 males and 92 females predefined. Would it have been much better if you would have like taken them and blinded the gender and then conducted the study and later on compared it with the actual?
So to avoid the bias which I can have. Yes, it could have been better, but it wasn't done.
Any other questions?
Nationally, it's presented very well.
Thank you, sir.
But we know that women are shorter, men are taller. So all measurements would be about 10% higher in men. And that's exactly what we saw. So, if there was a shorter male, then this measure will fail. If there was a taller woman, then this will fail. What do you think?
Sir, that's where the sample size matters. Since we had calculated the sample size with a level of significance of 0.1% and the power of 90%, I think it is a reliably good sample size to exclude such kinds of errors. Thank you, sir.
Is there any biological reason to compare left maxillary sinus separately and right maxillary sinus separately, height and width between males and females?
I can't think of any biological reasons,
In
but
the tables, you had
yes, sir.
the height of left maxillary sinus is compared between males and females separately to the right.
So since we don't know how these parameters differ between the sexes, we thought we'll analyze each parameter separately so that what if the right maxillary sinus height has some other difference compared to the left maxillary height. But I don't think there is any biological reason.
What was the age group?
So 20 to 70 years.
Yeah, so there is a relationship. Did you find whether the elderly people in this thing have the full complement of teeth or not? Because the absence of maxillary teeth can change the dimensions of the maxillary.
Yes, sir. That's why we had set the upper limit as 70 years. And in my studies, the CT scans of individuals above 60 years are very less, but I haven't checked exactly the presence of the teeth, sir.
Thank you.
There is one more question there.
About for the difference in the skull shape, geographical difference in the skull shape. So how do we perform for it, given the translational value of the different geographical people in different geographical regions? They tend to have different shapes, the skull shape alters on the head.
In my study, I have included only the people belonging to South India who come to JIPMER. So I don't think the geographical differences would matter in my sample size, sample group.
That's the translational value.
I'm sorry, I didn't understand the question.
When you apply the same to the wider population, then it does have the impact on the translational value. You cannot apply it for people from
Other population. I think the 95% confidence interval showed significant interval. So I think that would
that applies to
this book. Okay, I understand.
Okay, thank you, Ashwini.
Thank you.
Breastfeeding Health Initiative is a global initiative promoting optimal breastfeeding support in maternity facilities, and the practice of exclusive breastfeeding emphasizes its profound impact on fetal health and infant well-being. But there are some factors which prevent the initiation of exclusive breastfeeding in a neonate. So we need this here to discuss about this.
A very good afternoon to the complete galaxy of intellectuals and the esteemed judge panel. I'm Vinithan Reddy, a third-year MBBS student, and today I will be presenting my research project titled Maternal Factors Affecting the Usage of Mother's Own Milk in a Neonatal Intensive Care Unit of a Tertiary Care Hospital, South India. Amongst the various reasons which are responsible for neonatal deaths in our country, one of the most important reasons is preterm births, which accounts for approximately 35% of neonatal mortality in India. In order to tackle this particular problem, multiple low-cost interventions, which include delayed cord clamping, the provision of breast milk or mother's own milk, and kangaroo mother care have been proposed. The Lancet states that due to various maternal factors, which include but are not limited to maternal death, illness, or separation, approximately 40% of the infants in NICUs globally do not have adequate access to mother's own milk in the initial days of their life. In a country like India, where the incidence of low birth weight and premature infants is so high, we noted it disappointing to find that there was no Indian study which assessed the factors affecting the usage of mother's own milk in a NICU. And that is exactly what set precedent for our study. The primary objective of our study was to identify and elaborate the maternal factors which were affecting the usage of mother's own milk in a NICU. The secondary objectives were to assess the knowledge of proper breastfeeding practices amongst these mothers and to ascertain the proportion of mothers who were providing mother's own milk, PDHM or pasteurized donor human milk from the milk bank, formula milk, and different combinations of these sources of milk. Coming to the methodology, this was a cross-sectional analytical study which was done in the NICU of JIPMER. We performed consecutive sampling amongst those mothers whose neonates were admitted to the NICU. For a variance of 0.5, a precision of 5%, a response rate of 90%, and an N value, that is a sample value of 300 from previous study, we calculated a sample size of 125. Data collection commenced in December of 2022 and ended in February of 2023, and I administered the questionnaire uniformly to all mothers on day 3 post-delivery. Next up, coming to one of the most important aspects of the study, the questionnaire itself. After performing a thorough literature review and speaking with various mothers whose neonates were admitted to the NICU, we understood the various factors which could possibly be prohibiting the provision of mother's own milk within 3 days. This helped us develop a questionnaire, following which we then validated and also translated the questionnaire. The questionnaire consisted of 39 items, which was grouped into the following 5 domains: awareness of breastfeeding practices, awareness of KMC or kangaroo mother care, nursing and lactation support, which refers to support provided by the hospital, nurses, and doctors, psychosocial difficulties, and difficulty in the expression of mother's own milk. A positive response to at least 50% of the questions in the first 4 domains, and at least 1 question in the last domain was recorded as positive response or the criteria to satisfy that particular domain. Statistical analysis was done using Stata version 17. All descriptive variables were expressed either as mean with standard deviation or as percentages. For analytical purposes, we created 2 different groups. Group number 1 consisted of all those mothers who were able to provide at least some amount of mother's own milk by day 3. And group 2 consisted of those mothers who were not able to do so. Analysis between these 2 groups was done using Pearson's chi-square test or Fisher's exact test, whichever one was applicable. Coming to the results of the study, the mean gestational age of the infants was 35.5 weeks and the mean birth weight was 2 kgs, indicating that our study predominantly focused on a low birth weight and a premature population. We also noted that approximately 40% of mothers underwent cesarean section, 70% of them were first-time mothers, indicating that they did not have any previous breastfeeding experience, and approximately half of the mothers suffered from maternal comorbidities or illnesses. Our study also noted that only 30% of the mothers are exclusively providing mother's own milk, which is the required and ideal norm. Another 55% of mothers are providing some amount of mother's own milk in combination with pasteurized donor human milk or formula milk. These 2 groups collectively formed group 1 of our study, which consisted of 84 mothers who were able to provide at least some amount of mother's own milk by day 3. On the other hand, group 2 consisted of those mothers who were not able to provide mother's own milk by day 3. Upon comparing these 2 groups, we noted that the presence of breastfeeding awareness was significantly higher amongst those mothers who were able to provide mother's own milk by day 3. A few subsets which were part of this part of the questionnaire include exclusive knowledge of exclusive breastfeeding, complementary feeding, early breastfeeding, and common breastfeeding practices. We also noted that the incidence of psychosocial difficulties, some of which we took into consideration, included financial difficulties, the emotional status of the mother due to separation from the child, burden due to other children, was significantly higher amongst those mothers who were not able to provide mother's own milk by day 3. We also noted that the incidence of cesarean delivery was significantly higher amongst those mothers who were not able to provide mother's own milk by day 3. The other factors mentioned in these tables, which include the early initiation of kangaroo mother care, adequate nursing and hospital support, difficulty in the expression of mother's own milk, maternal education, maternal complications of previous breastfeeding experience was not significantly associated with the failure to provide mother's own milk by day 3. Similar studies conducted by Fernandez Medina et al. In Spain and Ikonen et al. In Finland showed that psychosocial difficulties were a significant barrier in the provision of mother's own milk. However, a study contradicted the findings of Hill et al. In US, who reported that maternal mood was not significantly associated with the failure to provide mother's own milk. A study also contradicted the findings of Fernandez Medina et al. In Spain, who reported that hospital routines and intervention by nurses was significantly associated with the failure to provide mother's own milk, which was not the case in our study. Our study is limited by a relatively small sample size of 125 mothers. We also noted that the participation of those mothers whose neonates were admitted to level 3 of the NICU was relatively less, indicating that our ability to gauge the sicker neonates was relatively less in this study. We conclude that psychosocial difficulties, the lack of awareness of proper breastfeeding practices, and cesarean delivery are significantly associated with the delayed initiation of mother's own milk or failure to provide mother's own milk by day 3. Hence, these mothers with these characteristics must be detected earlier and given more attention in the NICU. Although 80% of the mothers are able to provide at least some amount of mother's own milk by day 3, less than a third of the neonates, that's only 30% of the mothers in the NICU, are exclusively able to provide mother's own milk, which is the required norm. We propose that qualitative studies based on these 3 themes are required in order to understand these factors in depth. These are some of the references for my study. Thank you. I'll now open the floor for questions.
Look at 2 groups to comparing. We look at non-giving MR and its combinations and was unable to provide. What about the group which has only given MR but even not given?
Right. That comprises of only 30% of mothers, and a separate analysis of that was not done in this study.
Sir, why exactly the result was taken on day 3?
Right. Okay, so ideally, the time to administer the questionnaire would be immediately after the delivery of the mother. But keeping in time the convenience of the mother, and especially since we had a lot of cesarean deliveries, the mothers were not in a state to provide answers to our questionnaire. So that's why we decided that we will not disturb the mothers on the first 2 days. And to maintain uniformity, we decided on day 3. The reason why we didn't choose a later time period is because in the NICU, all the parents undergo regular counseling sessions. So they would get an adequate amount of knowledge from the counselors itself during that time. So that was the reason why we didn't choose a day later.
Also, we found a difference between delivery by LSCs between groups. But there was no difference between medical and obstetric complications within families.
No.
Why did that happen? What is the problem in LSCs and
Right. The main maternal comorbidities that we observed in this study included gestational hypertension and gestational diabetes. And the reason why most of the mothers who underwent cesarean section couldn't provide mother's own milk is because they were separated from their neonates for a prolonged period of time. And they were also not able to express adequate amounts of breast milk. The lactation was also not proper in the initial days following LSCS delivery.
complications, they also did not have this.
No, they did not show that relation in the study.
Oh, right presentation, but you said LSCS mothers could not provide, but did anyone, help her express the breast milk? It's not just, of course, happening in the parents. But if it is not there, did anyone help her to?
Yes, ma'am. So all the mothers who undergo LSCS delivery are placed in the separate ward. So they do have breast milk pumps and they do have support also over there.
That pumps for everyone.
Yes, ma'am. Manual expression also. The mothers were not able to do that is what I've noted in the study.
Right. No, when you have people to do that, then attendants are allowed to do that. If mother is not able to do.
The response that I would get from majority of the mothers is that we're not able to express breast milk.
This problem is coaching the mother.
You did a sample size estimation. correct?
Yes.
Why did you put your limitations like a limited sample size around it?
Yes, so this is actually a pilot study and it's one of the first of its kind study in India. So I would consider that as a limitation nevertheless, even though I did a proper sample size calculation. And I also consider it to be a pilot study still because majority of the studies conducted in the Western setting are qualitative studies.
I didn't intend to ask this question. I didn't intend asking this question, but because sample size was mentioned. In sample size calculation set, you assumed a variance of 0.5. What did that mean? And then you said proper sample size calculation, so I don't know, how to relate the two. What is variance in your sample size calculation?
A variance of 0.5 means that the difference between the data point and the mean would be 0.5.
The data point and what it could be, I don't really understand. Anyway, have a look.
Sure.
There is something amiss there.
Thank you.
Thank you. In recent years, ESL infections have witnessed notable changes in the array of positive agents, presenting new challenges to understanding and understanding about the management of these disorders. So now we have Sanjana with the next one.
Good afternoon. Good afternoon to one and all present here. My name is Sanjana and I'm check. Good afternoon to one and all present here. My name is Sanjana and I did this research project under the guidance of Dr. Mukta Vyavahara in the Department of Medicine. My project is titled Clinical and Laboratory Profile of Adult Meningitis and Meningoencephalitis. So meningitis and meningoencephalitis form an increasing disease burden globally as well as in India, as recorded by a 2016 global survey, which included 2.82 million cases worldwide. It also accounts for significant morbidity and mortality, but there is inadequate data on epidemiological trends and mortality due to meningitis in India. But because it is associated with such high morbidity and mortality and significant neurological deficit as complications after meningitis, a study is necessary. Pediatric population studies have been done before, but in the adult population and in the South Indian population, studies are lacking. There are only a few studies. So meningitis consists of an inflammation of the meninges in the brain, the leptomeninges, and it presents with a classical clinical triad, including fever, altered sensorium, as well as neck stiffness. Encephalitis includes an inflammation of the brain parenchyma, which includes altered mental status, fever, as well as seizures. So the main objective of my study was to describe the clinical and laboratory profile of meningitis and meningoencephalitis in adults for the past 5 years, which is spanning from 2017 to 2022. The study design was that of a retrospective type. Data collection was done over a period of 2 months, June to July 2023. The inclusion criteria included all the patients who were diagnosed by a physician with either meningitis or meningoencephalitis in the age group of 16 and above. Carcinomatous meningitis patients were excluded from my study. The sampling technique was consecutive, and based on medical records in this time period, about 100 cases of meningitis were admitted. So following approval from the UGRMC as well as the Institute's Ethics Commission, case records of meningitis and meningoencephalitis, which fell into the inclusion criteria, were obtained from Medical Records Department as well as the online database. And data was collected and inputted into a data collection proforma, including various details like history, physical examination, laboratory investigations, treatment administered, outcome, and discharge of the patient. The data collected was analyzed using Stata MP17, and the statistical analysis using descriptive statistics was done. The study included 111 participants whose mean age was 43 years, and there was a male preponderance in the disease with accounting of over 70 cases in males. Seasonal variation was seen in a time span of September to February, which is 6 months of the year, where there were 69 admissions. There were patients with comorbidities like HIV infection due to the immunocompromised state in 10 patients, 4 patients with diabetes mellitus, and 1 with unsafe chronic suppurative otitis media. The main catchment areas of the hospital were those of the neighboring districts to Pondicherry, which was Villupuram and Cuddalore, accounting for 64 cases. Coming to the symptoms of presenting illness, the main symptoms of presenting illness were according to the classical triad, headed by fever, followed by altered mental status, headache, vomiting, and seizures. Important to note that most patients, which is 78%, presented with at least 2 of the 4 symptoms: fever, headache, altered mental status, and neck stiffness. In examination findings, cranial nerve palsy, mainly facial nerve palsy, as well as absence nerve palsy, were seen in 9 patients. Low glaucoma coma scale was seen producing altered sensorium in 20 out of 53 patients for whom GCS was recorded. Signs of meningism like neck rigidity, Brudzinski sign, and Kernig sign were seen in 27 patients, and this was not a significant symptom of presentation, but it was seen as an examination finding. Focal neurological deficit was seen in 17 patients. CSF analysis was performed in 86 patients, and abnormal parameters such as low glucose or raised protein or abnormal cytology was seen in 74 of these samples. Coming to the etiology, about 1/4 of all of the cases were seen to have tubercular meningitis, which was diagnosed either by CT scans, raised ADA levels, or being a previous case of pulmonary TB. 9 patients had scrub meningoencephalitis. 8 were of bacterial etiology, which was isolated by culture. 4 had cryptococcal meningitis, which was done by India ink staining, and 6 patients had viral encephalitis. The rest, 50% of patients, had a diagnosis of meningitis based on purely a clinical diagnosis by the physician. Coming to the treatment and outcomes of the various participants, it was according to the etiology. Antibiotics for as empirical treatment was given in about 54% of patients. Anti-tubercular therapy along with steroids for those with tubercular meningitis. Antivirals with antibiotics for those with suspected viral etiologies, and antifungals with cryptococcal. This was roughly in correlation with those who were diagnosed with these etiologies. Surgery like ventriculoperitoneal shunt surgery was performed in 4 out of the 31 patients who were given anti-tubercular therapy. Recurrent meningitis was seen in 6 patients, and this was in some cases due to a chronic suppurative otitis media, and in 1 patient due to X-linked A-gamma globulinemia. The median length of hospital stay was 9.5 days, and 66% of patients were discharged without any significant neurological deficits. The mortality found in our study was 29%. On comparing this study to a similar one done in South India, there was a higher incidence of tubercular meningitis in our population, which was 25 as compared to 15% in their study, whereas bacterial, viral, and cryptococcal meningitis were all found in a lesser incidence in our study. In conclusion, typical presentation of the classical triad of meningitis is seen in majority of patients. The most common etiology identified in our study was tubercular meningitis. Empirical treatment was administered to most of the patients, even in the absence of a CSF report. And a good patient outcome was seen in 66% of cases. The main limitation of my study was its retrospective design, which the problems arose like incomplete case records. So better record keeping and regular audit of meningoencephalitis for better clinical manifestation, documentation, as well as management is necessary. These are my references. Thank you.
So, first of all, I would like to ask you one question. You mentioned that 12 of your study participants had clear CSF, with no CSF abnormalities. So, how did you include them in the meningitis and meningitis that you took on those cases?
Yeah, so not all etiologies of meningitis will have deranged CSF parameters. So especially viral meningitis. So this is purely based on a physician diagnosis that these patients were also put into the diagnosis based on symptoms.
It's been a very nice presentation. I had a question about the same thing. you said 86 people, 86 patients had LP, but on the same slide, you also had a pie chart where N was 111. And you showed the specific etiology,
Yes,
all of them organisms.
yes.
So why the mismatch? And did everyone who had an LP have a specific organism grown?
No, sir. Out of the total etiologies, only 52 were assigned a proper microbiological etiology. The rest were purely based on a physician diagnosis. And CSF was not performed for all of the patients. Only 86 patients had a CSF analysis.
Pie chart you had 111. And
That was including all of the patients with the diagnosis of meningitis. I did not take that into account. I did include that in.
Since 50% of the cases have no CSF analysis done, the study that you compared yourself with, said that your study showed a higher incidence of tuberculosis etiology compared to black fever. With that study, which you compared, did they do CSF analysis for all patients?
Yes, sir. CSF analysis was performed, and out of the 97 cases in that study, those also had a confirmed microbiological etiology only for 62 cases, not for all of the 97 cases.
It's a nice study. Now, after completion of the study, apart from the record issues, like 50%, how will you try getting an etiology for that 50%? In future.
In future patients,
Yes.
not in those patients.
What the message you give for all the audience here and faculty?
So, since meningitis and meningoencephalitis are emergency medical conditions, and empirical therapy is the mainstay of treatment. So, in order to prevent significant mortality in the patients, but streamlining the therapy with specific antibiotics based on etiology can be done after giving the patients empirical therapy.
We have a reference laboratory, the same the panel wanted testing should be improved. And anyway, it's a serious diagnosis.
Yes.
I don't think you can just manage by clinical diagnosis and treat the patient.
One thing I found the mortality also very high. And what is the reason, especially when we come to our institute? It's our institute.
Yes.
How can we resolve the mortality? Is it that there's limited rate or?
Yes, ma'am. Because of the nature of our center being a tertiary care referral center, the patients who are referred to our center might have been in a worse state than if they presented at a local level, a lower level healthcare.
If you repeat it,
It's a mixture.
yeah.
It's a mixture. To the best of my knowledge, I am not working in that area, but meningitis does not have as high mortality as encephalitis. So this was meningitis, meningoencephalitis, and encephalitis. So we don't know the relative proportion of
They're
those.
taken each other deaths.
Due to each etiology, I'm trying.
The viral, don't you can do much about it.
Thank you, Kalina.
The psychological and emotional well-being of the patients undergoing surgical procedures is an integral part to overall success of the medical and surgical intervention. So we have Ashita with a paper to throw some light on the behavioral preparedness before surgeries.
Good evening. I'm Ashita. I did my project in the Department of Surgery under the guidance of Dr. Vikram Kate. My project is about the assessment of behavioral preparation for surgery in patients undergoing emergency abdominal surgeries and its effect on the recovery outcomes. Traditionally, when we talk about patient preparation, we tend to focus on physical preparation, but the behavioral aspect is largely overlooked. The aim should be to have a more patient-centered approach with the emotional well-being as an integral component. Most of the negative effect associated with this is due to the paucity of information that the patients receive, such as no information about the underlying condition and treatment.
A brief conversation regarding the same between the treating doctor and the patient could result in a better comprehension and processing of emotional states, which could in turn hasten post-operative recovery. Therefore, to improve post-operative outcomes, emphasis must be placed on pre-operative preparation and optimization of the patient for surgery. These are some of the interventions that have been used in previous studies. It includes cognitive interventions, relaxation methodologies, and hypnosis. The aims include to assess the behavioral preparation using a questionnaire and also to determine the effect of presence or absence of behavioral preparation for surgery on post-operative pain, and length of hospital stay. This is a prospective cohort study with a data collection period of 2 months. All adult patients undergoing emergency abdominal surgery were included, but patients who were not extubated within 48 hours of surgery and patients who underwent intraoperative or postoperative mortality were excluded. Consecutive sampling was used, and from the register of emergency surgeries, it was found that on an average, 100 patients are taken up for emergency laparotomy for 2 months. So assuming the same number of cases, the sample size for this study was taken to be 100. Among all the patients enrolled, pertinent patient information such as age, hospital number, gender, diagnosis, type of surgery, and history of previous laparotomy was recorded on the day of the surgery. On post-operative day 3, the patient and their attenders were given a comprehensive questionnaire. The questionnaire was specifically designed to holistically assess the adequacy of preoperative behavioral preparation and overall satisfaction with the treatment regimen. Throughout the duration of their hospital stay, a systematic follow-up process was maintained. This included assessment of the postoperative pain on postoperative day 3. For this, a visual pain analog scale was used, which scaled their pain from 0 to 10, 10 being the most severe type of pain. Length of hospital stay was also documented. Questionnaire related to the patient satisfaction and behavioral preparation was based off of the short form patient satisfaction questionnaire, also called as the PSQ-18. This was developed by Marshall and Hayes, and it has been widely used in multiple studies. The questionnaire measures patient satisfaction with the assistance of 18 questions, which can be classified into 7 domains. The domains are general satisfaction, technical quality, interpersonal manner, communication, financial aspects, time spent with doctor, and accessibility and convenience. Some of the important questions are, number 6, doctors are careful to check everything when treating and examining me. Number 13, doctors sometimes ignore what I tell them. Number 10, doctors act too businesslike and impersonal towards me. Number 5, I feel confident that I can get the necessary surgery I need without being held back financially. We can see that there are negative as well as positive questions. Each question is accompanied by 5 response categories, from strongly agree to strongly disagree with uncertain in between. A scoring system was developed for each response that ranges from 1 to 5. And all items were scored in such a way that high scores reflect satisfaction with the behavioral preparation received. After item scoring, items within each domain were averaged together to create 7 subscale scores. All continuous variables were summarized as mean with standard deviation or median with interquartile range based on the normality of the distribution. All categorical variables were summarized as frequency or proportions. Satisfaction of patients undergoing surgery with the behavioral preparation that they received was expressed as a proportion with 95% confidence interval. T-test and ANOVA test were used to compare outcome variables, that is the postoperative pain and the length of hospital stay. Statistical significance was determined at p-value of 0.05. Out of the total 100 patients undergoing emergency abdominal surgery, most of the participants were in the range of 31 to 45 years, and they were predominantly male. 55 people were male. Majority of the participants underwent surgery for hernia, and 39% of the participants had undergone laparotomy previously. 13% of the participants felt that doctors sometimes ignore what they tell them, and around 8% were uncertain about the same issue.
From this table, we can see that the communication domain saw the most satisfaction with a mean value of 4.23 out of 5. And time spent with doctor had the least satisfaction at 3.89. And there was a study conducted in West Bengal, which also showed that the time spent with the doctor had the least satisfaction score. That was also conducted in a rural hospital. So that might indicate that because of the high patient load, the doctors do not have sufficient time to spend with each and every patient. But at the same time, the communication value is high. So this means whatever the doctors are communicating, they are communicating in a concise, crisp, and understandable manner. But a study in Nigeria showed that the least satisfaction was in the financial domain. But our financial aspects had a significant satisfaction. This is because the government pays for most of the procedures over here. So almost all the patients were satisfied with the financial aspects. But that's not the case in Nigeria. Coming to the outcome results, post-operative pain was recorded using a visual pain analog scale. It was measured from 0 to 10. And mild pain was categorized as anything less than 4, and moderate to severe pain was anything which is equal to or greater than 4. 56% experienced moderate to severe pain on post-operative day 3. There was a correlation between the pain scores and the satisfaction scores, which was found. There was a 35% reduction in satisfaction in the moderate to severe pain category compared to the mild pain category. Length of hospital stay. Univariate regression was done for the length of hospital stay, but there was no significant association found with any of the variables. Coming to the conclusion, although numerous patients were satisfied with the behavioral preparation that they received, there were also a number of patients that were dissatisfied. By identifying areas where patient satisfaction can be improved, such as time spent with the doctor-patient interactions, and the convenience of services, healthcare providers can enhance the overall patient experience and potentially contribute to better surgical outcomes. This may also lead to reduced violence against healthcare workers, and the incorporation of training programs for surgeons and staff aimed at providing behavioral preparation could be beneficial. Thank you.
You administer the question, have you administered the questionnaire or were they asked to the questionnaire?
No, we ask the questions, and depending on how they answer, we mark the score, because most of them are not in a situation to understand what exactly is being asked and what is the difference between 2 or 3 questions.
This is intended to be an investigative. At that time, it was intended to be self-administered questionnaire. So how will that be patient responsibility?
I mean, over here, there are a lot of severe cases, and most of them are in very emotional states. So we felt like we would get better results if we listened to them and asked them whether they strongly agree or agree. So based on our analysis of how they felt, we marked it. Or else most patients would just put satisfied for everything because they're being treated. So we wouldn't get a proper response if we self-administered it.
Wouldn't there be a bias because like we are from healthcare and we are asking them the questions, and wouldn't it be a bias?
We mark it.
They are answering us because we are the native ones. So
No, we don't tell them that we're doctors. We told them that we're students and we want to know how we can help them better. So we tell them that we know you're here, we know you're suffering, and we know you've gotten treatment, but we want to know what we can do better so that you can get better services in the future.
one small question. This questionnaire was administered post-operatively. So and you are asking for the behavioral preparedness for the surgery.
Yes.
It was done. This was emergency surgery.
Yes.
So if you do it post-operatively, if you administer the questionnaire post-operatively, wouldn't it create a bias for that as well? Because the pain factor will add to the thing.
Yeah, so the thing is, since it's emergency surgeries that are being considered, it's very difficult to go pre-operatively run to the hospital at 2 a.m. when their surgery is happening and say, tell me what's your behavioral preparation proper. They would have yelled at me saying, I have to go to surgery. Why are you asking me all this now? So that's why we asked them later on post-operatively, but we asked them specifically before the operation, did they explain everything to you properly? Were you satisfied? Did everything happen properly?
But like, is this PSQ designed for emergency surgeries or OP basis?
The same questionnaire has been used in West Bengal, so
Was this designed for this kind of study or for emergency?
It's been used in so many studies that it can be designed for anything. It has also been used in emergency surgeries. I have some references.
Let me just the last question. What are the technical qualities the patient assessed?
Ma'am, technical quality essentially means that do they feel like the hospital is equipped to treat them? Do they have everything necessary to treat them? Like when they're staying.
Difficult question to get done.
Confused behavioral preparation, I thought there was one slide which was hypnosis and relaxation. I thought the study themselves were giving some sort of behavioral preparation for the patient, but I think I understood wrong here. Everything seems to be what we have to change, right?
So like it's an observational study, it's not an interventional study. That was just to show what other studies have done as interventions.
Whose behavior is being changed, the doctors or the patients?
No, it's to analyze what the doctors can change so that patients are more satisfied with
Doctors'
what
behavior
they.
is being changed. Okay.
Thank you.
Thank you. Moving on. CT scans probes. Move on to presentation number 10. CT scans prove a vital diagnostic tool in cases of traumatic brain injury, but it is at the same time associated with the risk of attending radiation exposure. This next study by Rakesh Aggarwal will look at the degrees of adherence to NICE guidelines in managing traumatic brain injury and its effect on reducing excess CT scans.
A very good afternoon to one and all present here. I am Zahid Said Iqbal, and today I will be presenting a research project which I've been working on over the past year, where I assess the adherence rate to the NICE criteria for emergency CT scans in head trauma patients and the impact that has on excess scans and radiation exposure. The study was done in the Department of Neurosurgery. It is a well-established fact that exposure to ionizing radiation from CT scans increases the risk of cancer, and studies have found that this risk is particularly higher in children. One notable study, which was published in Nature Medicine just at the end of last year, and some of you may have read this article in the Hindu as well, it stated that for every 10,000 children who receive a CT scan today, 1 to 2 are expected to develop a hematological malignancy due to radiation exposure in the subsequent 12 years. The National Institute for Health and Care Excellence in the UK, or NICE for short, it has come up with guidelines for management of head trauma patients, and the primary objective of these guidelines is to reduce the overimaging by CT scans. So what these guidelines do is they provide us with a framework for the selection of patients for head CT scan, and based on the presence of certain risk factors, a scan could be indicated within 1 hour of examination of the patient or within 8 hours of injury of the patient. Otherwise, if the risk factors are not present, then a scan may not be indicated at all. We had the impression that the current adherence rates to these guidelines in our emergency department were suboptimal, and we wanted to study that. The primary objective of our study was to estimate the proportion of CT scans which are not indicated by NICE guidelines. We then wanted to find the proportion of positive radiological findings in the unindicated group of patients. We wanted to project the potential reduction in scans and radiation exposure if we adhere to the guidelines completely. And we wanted to determine if unindicated scans would cause a change in the hospital stay duration. This was a retrospective cohort study, and we included all patients who underwent head CT scan for a suspected diagnosis of traumatic brain injury in the month of October 2023. All patients who underwent head CT for any other indication or whose case records could not be retrieved for any reason were excluded from the study. The sample size was calculated to be 254, and this calculation was done based on a small pilot study that we conducted in the same emergency department. So first what we did was we collected the list of all patients who underwent an emergency head CT scan in October 2023 for TBI. We then retrieved the case records from MRD, and then we made an assessment for each case if the CT scan had been done in adherence to the NICE guidelines or not. In addition, for each patient, we also noted down the positive radiological findings in both the indicated and in the unindicated groups. Then we checked if these positive radiological findings altered the management of the patient in any way. We also collected the dose length product from the PACS data of the CT scans and then converted the dose length product to the effective radiation dose in millisieverts using an online calculator. And this helped us to quantify the radiation exposure for each patient. We also recorded the duration of the patient's hospital stay, and in order to establish a relationship between the duration of stay and the indication according to NICE criteria, we use the chi-square test. These are the results of our study. Out of the 254 patients who were studied, we saw that 118 patients, which is 46.4%, had been scanned without a NICE criteria match. Now, this was almost half the CT scans in the month of October, which were not matching NICE guidelines. I have shown you two pie charts here for adults and children separately, and you can see that the number of unindicated scans, or rather the percentage of unindicated scans in both the groups, is fairly similar, 47 and 42%. Now, we were interested in the unindicated group of patients, so we looked at the positive radiological findings in that group, and we found that 32 patients, that is 27.1%, had positive radiological findings, with a simple fracture being the most common finding and a contusion being the second most common finding. We then saw that out of these 32 patients, in 17 patients, these positive findings caused a change in management. The most common change in management was the addition of anticonvulsant drugs. This was seen in 9 patients out of 17. In addition, we also studied the CT scan characteristics, and we saw that for each patient who underwent an unindicated CT scan, he or she was exposed to a median radiation dose of 1.7 millisieverts. In addition, we also observed a tendency to prescribe repeat CT scans in patients in whom the first scan itself was not indicated in the first place. So there were 10 patients who underwent 2 CT scans, and there were 3 patients who underwent 3 CT scans. We also, as I said, we used the chi-square test in order to establish a relationship between the duration of hospital stay and the NICE criteria indication. And we found that there was a statistically significant relationship between the non-indicated scans and a shorter duration of hospital stay, with a p-value of just 0.002. So we established that there is a very poor adherence rate to NICE guidelines in our emergency department. However, this may not necessarily be a bad thing. Obviously, if there is poor adherence to NICE guidelines in the ED, there is excess exposure to radiation to patients, and that is further compounded by the fact that there is a tendency to prescribe repeat CT scans in patients in whom the first scan itself was not indicated in the first place. Another problem that occurs with poor adherence is that, like we noted, the addition of anticonvulsants was the most common change in management in these patients. And why I call that a problem is that the evidence to support the use of anticonvulsant drugs in the management of TBI patients is not very strong, and long-term exposure to these drugs and to their adverse effects is not very desirable. On the other hand, a more liberal approach to the selection of patients for head CT scans seemed to have advantages. There was first the fact that there were positive CT findings in the unindicated group of patients, and this shows us that the NICE criteria is not perfect. The sensitivity in our study was found to be 84.1%, and that in other studies was also found to be in a similar range of 80 to 85%. Also, another thing that we observed was that there was a positive relationship between unindicated scans and a shorter duration of hospital stay. What this means is that a more liberal approach might have been used to clear a congested emergency department quickly, since patients who were scanned could be diagnosed quickly and then could be treated more quickly, and they could be discharged earlier. Another interesting conclusion that we came to based on the results of our study is that the risk of malignancy from excess radiation exposure does not seem to be as high as was initially presumed. To put this into perspective, we counted that there were 2,943 head CT scans done for TBI in our ED in the year 2023. If we assume a similar adherence rate and age distribution as was observed in this study to be present throughout the year, then 102 children would have undergone unindicated CT scans last year. So that would mean that it would take us 98 years in order to prescribe 10,000 unindicated CT scans. Why the number 10,000 is important is because, as I referenced a study in the introduction to this presentation, it had found that for every 10,000 children who are examined today, 1 to 2 are expected to develop a hematological malignancy. So that would mean that there would be a hematological malignancy only every 98 years due to excess radiation exposure, and that risk is not very high. So, to conclude, we can make 2 recommendations on the basis of this study. Firstly, of course, there is a need to emphasize and formulate strategies to encourage the better adherence to NICE guidelines in our emergency department. However, at the same time, on the other hand, we need to design studies to assess if absolutely strict adherence to these guidelines impacts outcomes like mortality, especially in a setting of a highly congested emergency department like ours. And this, we believe, is a pertinent need. These are the references for my study. I would now like to open the floor up for questions.
So, Zahid, I wanted to ask you, did you do the cost benefit analysis of the scans with, like, if you can provide them a prophylactic dose of anticonvulsants for like for 2 weeks, like, would it be better to like expose them to radiations or?
No, we did not assess the cost benefit analysis because, in a sense, the primary objective of this study was to assess the radiation exposure and the risks that radiation exposure has in these patients. So we were not looking at the cost of the interventions or the different CT scans that were taken.
For what specific indications were the CT scans?
There were a number of indications. The most common indication was any sign of basal skull injury. Signs of basal skull injury include an ENT bleed or battle sign or hemotympanum raccoonized and so forth. So this was the most common indication. Other indications included a low GCS score and so on and so forth.
So I do have a doubt here. So one study you presented that they were added anticonvulsants after some non-indicated CT scans. So what are the indications for these anticonvulsants? Were they experiencing convulsions or are they asymptomatic and just because they saw some radiological findings they started?
The use of anticonvulsants in the ED for traumatic brain injury patients is mainly prophylactic. So in case an intracranial bleed is detected on the CT scan, then these drugs are used as a prophylactic measure. But as I mentioned, the evidence to support the use of these drugs in the prevention of early and late onset seizures is not very strong, which is why I said that this was a limitation of the fluorescence noise guidance.
So these unindicated CTs are more like a double sword.
More or less, you can say.
Very good presentation, very confident. But at the same time, because you made very impassioned arguments, I think I must request you to tone down the message. The fact that you find those who had where CT was not indicated might have been expected to have a much shorter hospital stay anyway, because they had minor injury. So what you noticed may not be an effect of getting a CT. It might actually be that actually they stayed even that long because they had to get a CT done. If a person had decided no CTs to be done, they could have been sent as quickly. And effects add up. The fact that you do so many CTs means that people wait for the CT. There is a queue for CT. So these are very difficult arguments to look at.
So, in our study, actually, the head injury patients who came to the ED but were not scanned, because they were probably not indicated according to NICE guidelines or because there was no clinical indication, they were not included in our study.
If you had looked at them,
yeah,
you would have found that they would have got discharged possibly even faster.
Probably.
Even then you can't compare. Problem in observational studies is you can't really compare.
Yes.
But my point is that drawing conclusions like this is sometimes not necessarily right.
And
Interesting study. So were there any readmissions and CT was second for the done after they came for the readmission?
So there were readmissions, but then we did not consider them as a separate case. In case there was a readmission, like for the same brain injury, then we only looked at the head injury that they presented initially with, because these guidelines are for the initial management of patients with head injury within 1 hour and within 8 hours of the injury. So those readmission CT scans were not considered in this study.
Continuing with what sir mentioned, we started with the data from our casualty.
Yes,
that projected for 98 years for the community.
No, sir. I use the data from an international multi-center study. It was published in Nature Medicine, and that found that for every 10,000 children examined today, 1 to 2 are expected to develop a hematological malignancy. So based on that, I just found the number of patients who undergo an unindicated scan in our ED, and I've drawn a conclusion that it would take us 98 years to do those many scans.
That's because ours is not the only CT scan which is happening. There are more CT centers outside, more radiation.
Oh, yes.
And CTs are done for many other indications. That is, or many other non-indications. So that is the problem.
Patients with suspected TPI, many of them, at least when I told them, a significant number of them are programming accidents under the influence of alcohol.
Yes.
So patients don't respond clearly in the ED, and naturally the GCS scores are lower. So it's very difficult for the clinician to, I mean, retrospectively, you can look at the CT and say that the CT was not required at all. But on the ground situation, the patient is not responding clearly. It's difficult for the clinician to say that poor response is because of an eaten brain injury or whether it is because of the influence of the alcohol.
Sir, but in both cases, like if there was a low GCS score, in the case records, it would have been recorded as a low GCS score, and that is an indication according to NICE guidelines for a CT scan. On the other,
What I'm saying is radiologically there might be no injury for it, but the low response or poor response is because the patient was disoriented and under the influence of alcohol when they came to the meeting.
yes, sir, but in our study, we are not looking at the non-findings on the CT scan in the indicated group. We're looking at the positive findings in CT scan in the unindicated group, and then studying that further.
Yeah, whatever GCS was recorded, we should take it to the next field.
Thank you.
Thank you.
So, no questions. We now have the next presenter, Mohammed Karan. The study is addressing the problem of protein energy wasting in the pediatric population with chronic kidney disease.
A very good evening to all present here. Myself, Mohammed Kaif, and I'm going to present my research titled Assessment of Protein Energy Wasting in Children with Chronic Kidney Disease, a cross-sectional study. So, coming to introduction, chronic kidney disease is an ongoing global burden with a prevalence of 15 to 74.7 cases per million children. The term protein energy wasting is specific for metabolic and the nutritional derangements occurring in CKD. It also includes the nutritional as well as inflammatory component. The term PEW was first proposed by International Society for Renal Nutrition and Metabolism, which defined it as the state of decreased protein stores as well as energy fuels. So this slide shows the pathophysiology of PEW. As you can observe, not only malnutrition, apart from malnutrition, inflammation, hypercatabolism, as well as uremic toxins contribute to PEW, which in turn leads to increased risk of infection, cardiovascular diseases, and leads to increased mortality, morbidity, and decreased quality of life. So, this slide demonstrates the global burden of PEW based upon a meta-analysis of PEW prevalence. As you can observe, our country over here is in the dark orange color, which indicates the prevalence of PEW ranging from 61 to 80%. And this meta-analysis is based upon adult studies only and not in pediatric age group. So, till now, there was no pediatric studies reporting PEW until 2014. So the rationale for my study is that PEW in children is an understudied and not well characterized parameter, while there are several challenges in applying the adult-defined PEW criteria for pediatric population. In 2014, Abraham et al. Proposed a modified pediatric-specific scoring system for PEW, which has the following 5 criteria: biochemical criteria, reduced muscle mass, reduced body mass, and reduced protein intake, poor growth. The objectives of my study is to determine prevalence of protein energy wasting in children aged 2 to 18 years with chronic kidney disease stage 2 to stage 5D. The secondary objective being to describe the clinical characteristics of children with CKD having PEW. The methodology of my study, coming to methodology, see here, it was a cross-sectional descriptive study conducted in Department of Pediatrics at Pediatric Nephrology Clinic. Sample size of 150 was proposed based upon the sample size formula for descriptive studies, while the sampling technique was consecutive sampling. The inclusion criteria was all children aged 2 to 18 years with CKD stage 2 to 18 years, 2 to 5D, while the exclusion criteria was children who have been recently admitted within a month of screening for a prolonged period of more than 7 days. Study procedure. All study participants were screened for eligibility and informed consent was obtained. Demographic parameters were recorded, while necessary information for satisfying the definitions of PW were recorded. The data collected include demographic data, parameters of CKD, parameters of PW, as follows. Now let us see the criteria of PW and the definitions. So these are the 5 criteria as I opined before, which includes biochemical, reduced body mass, reduced muscle mass, decreased protein, decreased appetite, and poor growth. So these are the 3 definitions. The minimal PW for minimal PW definition, all children who satisfy 2 or more than 2 criteria, 1 through 4 are met. Standard PW definition, all children who satisfy more than or equal to 3 criteria, 1 through 4 are met. While the modified PW criteria, which is pediatric specific, more than or equal to 3 criteria, 1 through 5 are met. Statistical analysis. The data was presented. The data was checked for normality using Kolmogorov-Smirnov test, while variables are presented as median, mean, proportions. Continuous variables were analyzed using student t-test, magnitude U test, while categorical variables we analyzed using chi-square test. So coming to results. So these are the different characteristics. 79% of the participants were males, while the median age at enrollment was 10.6 years. 1/3 of the participants were in CKD stage 2, while 20% of the participants were in ESKD. Coming to etiology of CKD, majority of the participants had congenital abnormalities of kidney and urinary tract as a major abnormality, more specifically obstructive uropathy, apart from chronic glomerular diseases and others. Coming to growth parameters, 78% of the participants had reduced muscle mass, 18% of the participants had reduced body mass, while 21% of the participants were short-statured. 84% of the participants were reported to have good appetite, while the rest of them were reported to have poor appetite. So these are the lab parameters. We can observe that the median eGFR was 42, and the CKD comorbidities. As we can observe, out of the total 150 CKD participants, the major comorbidity was metabolic acidosis, followed by CKD MBD, hyperphosphatemia, and anemia. So coming to the main primary objective of my study, which is the prevalence of PW across different definitions. 20% of the participants satisfied minimal PW definition, while 13.3% of the participants satisfied standard PW definition, while modified PW definition, which is specific for pediatric age group, was satisfied by 26% of participants. So this table depicts the prevalence of PW across different stages of CKD. And this chart and this pictorial representation depicts the same. As we can observe, the prevalence of PW is nearly equal in all stages of CKD, with marginally high in ESKD. So these are the clinical characteristics of children with PW. As we can observe, children with modified PW are more likely to be short-statured, are more likely to be having severe wasting and moderately underweight. So this diagram depicts the frequency of various parameters that contribute to PW in children. So here we can observe that reduced muscle mass contributes the most, followed by hypoalbuminemia, followed by reduced body mass and short stature. This diagram depicts the prevalence of PW indicators across different stages of CKD. Here we can observe that reduced muscle mass contributes the maximum, contributes most, while reduced serum albumin, reduced serum transferrin, and short stature contributes in ESKD patients. Coming to discussion and comparison of my study with the studies that have been conducted earlier. So here we can observe that there are 2 studies conducted earlier. One is Abraham et al. Of USA in 2014. So here we can see that the ESKD prevalence in their cohort was 20%, while prevalence of modified PW was 15%, and these being the major contributing factors. While in case of Aggarwal et al. At Bangalore, the ESKD prevalence was 40%, while the prevalence of modified PW was 34%. This is primarily because of high prevalence of ESKD patients in their cohort. And these were the factors contributing the most to modified PW. In our study,
the prevalence of ESKD was 20%, while modified BW was 26%. In our study, the most contributing factors were reduced muscle mass, reduced body mass, short stature, and hypoalbuminemia. The merits of my study is that it is a relatively large cohort of CKD children with PW assessment from a single center, and most of the parameters of PW were available for systematic evaluation. In conclusion, the prevalence of PW in our cohort was 26%. PW was prevalent in all stages of CKD with higher numbers in ESKD. Reduced muscle mass, reduced body mass, and short stature contributed the most in modified PW. Thank you.
When is the PW criteria applied? When was this criteria applied? What was the mean time between diagnosis of CKD to recording the data?
So,
how long would these children have CKD before you?
So this is the age of diagnosis, median age of diagnosis, while this is the median age of enrollment. Children may followed up between these, and from this we get the median age of follow-up. We had applied these definitions at enrollment.
The implication of this.
So the implication of the study is that we need this is a cross-section study, but we need a long-term longitudinal study to determine and predict the incident hospitalization, comorbidities, renal outcomes associated from using these PW definitions.
What are you going to do? Is there anything that you can prevent? There's some implication. You're waiting the data after that.
So this is a descriptive study. This data can be utilized in designing further studies, which will predict the hospitalization of children with CKD, which predict the comorbidities of children with CKD.
Right.
Thank you.
Now I call upon our final presenter on the stage. We have JIPMER, presentation number 12. The study investigates electrolyte disturbances in the post-renal transplantation.
Good evening to all respected faculty and all my fellow students. It has been a long day, so I'll keep it short and sweet. My project is on assessment of serum electrolyte and mineral abnormalities and its clinical determinants in kidney transplant recipients the first 72 hours after transplant. It's a retrospective record-based study. The study was done by Dr. Srijit Parmeshwar sir from Department of Nephrology and Dr. Surya K sir from Department of Urology. So background, if you all know, kidney transplantation is the treatment of choice for patients with end-stage renal disease. The restoration of graft function is accompanied by diuresis, which leads to dyselectrolytemia in the post-op period of 72 hours. So the ideal IV fluid for replacement that is due to the dyselectrolytemia and the diuresis is not defined. And in JIPMER, we use normal saline plus 5% dextrose in the ratio of 2:1. But normal saline usage is associated with a high incidence of hyperchloremic metabolic acidosis. So using more physiological fluids or balanced electrolyte solutions may help overcome the drawbacks of current fluid therapy. And our study was aimed as was planned to inform us about the abnormalities of electrolytes and their determinants. So the objective was to assess the electrolyte and mineral abnormalities in the first 72 hours after transplant. And the secondary objectives were to assess the clinical factors associated with these abnormalities and the association of these abnormalities with urine output. Coming to the study design, as I already stated, it was a retrospective record-based study. Due approval was in the form of waiver of consent was obtained from IEC. The data collection period was over 2 months, and all adult patients who underwent living donor kidney transplant during study period from Jan 2019 to May 2023 was and who received standard protocol replacement fluid of NS and 5% dextrose were included. And patients who required dialysis and who had post-op complications requiring re-exploration of surgery were excluded. So we had collected a list of transplant recipients from the database in the nephrology department, and digitized medical records were retrieved, and the required data was extracted from them and was entered into MS Excel using a predefined data collection program. So the parameters studied were grouped into 3 groups: preoperative, intraoperative, and postoperative. Preoperative, we mainly looked at the age, gender, pre-transplant, post-dialysis dry weight, and medications including antihypertensives and all the serum electrolyte and serum creatinine and electrolyte levels. Intraoperatively, we looked at IV fluids and blood transfusion, urine output, and diuretics given. Post-operatively, again, we looked at the weight, the fluid intake, that is enteral and parenteral documented separately, train volume and stool volume, along with the blood and electrolyte parameters. The IV fluid again administered on each day, immunosuppressive medications, that is mainly tacrolimus, and complications like hypertension, seizures, vomiting, and so on. The sample size was estimated at a 5% significance and 10% relative precision. The sample size is 83. The sampling technique was done by convenience sampling, and the statistical test used was chi-square or Fisher's exact test to determine the association of electrolyte and mental abnormalities with the different clinical and treatment characteristics that I had shown on the previous slide. The statistical analysis were carried out at a 5% level of significance, and the p-value was less than 0.05 was considered significant. Coming to the results, the mean age was around 32.1 plus or minus 9.4. The weight of the patient was 9.4, and most of the patients were male, 82% were males. And for coming to the etiology of CKD, I would like to draw the attention to the 2 main etiologies, that is CGN, chronic glomerulonephritis, which accounted for 28.75, and CKDU, chronic kidney disease of unknown origin, which accounted for 27.5%. Sorry, CGN accounted for 28.75%. And the electrolyte abnormalities of coming to the electrolyte abnormalities, the hypokalemia was the most prevalent electrolyte abnormality, according to a percentage of 62.1%, followed by hyponatremia, 58.5%. Hypocalcemia was observed at 58%. Phosphatemia, hypophosphatemia at 56.4%, and hypomagnesemia at 56%. Hyperglycemia is universal and it is observed in all patients that we had studied. These are the general random parameters up to day 2 morning. I had mentioned initially it's 72 hours of transplant, but here the parameters are only given till we have taken parameters only till day 2 morning, that is actually 48 hours. The reason being from 48 to 72 hours, the graft function that of the transplanted kidney significantly improves. And so the incidence of dyselectrolytemia also is pretty less. So it doesn't, the need of it being documented is not warranted. This is a line graph showing the different parameters I had shown in the previous slide. This I had already mentioned, the record of patients are included. So coming to each individual electrolyte abnormality, low dry weight, low preoperative serum potassium and phosphorus, higher preoperative serum calcium, lower preoperative serum creatinine, higher tacrolimus C0, the initial tacrolimus dose given was associated with hypokalemia. Younger age and low serum sodium in the preoperative period was associated with hyponatremia. Low preoperative serum magnesium was associated with hypomagnesemia. Higher levels of serum phosphorus and potassium and lower levels of serum calcium were associated with hypocalcemia. And lower preoperative serum phosphorus and potassium were associated with hypophosphatemia. So in this retrospective study, we found that the incidence of electrolyte abnormalities was very high in the early postoperative period. We said hypoglycemia requiring insulin administration was universal in the first 48 hours. The incidence of hypokalemia, hypomagnesemia, and hypophosphatemia was higher than previously reported from similar studies conducted in foreign centers. Other factors influencing serum electrolyte levels are exposure to drugs like tacrolimus, glucocorticoids, and diuretics. All these factors contribute to our studies' high incidence of electrolyte abnormalities seen in the immediate post-transplant period. DGF, delayed graft function, is unusual after an uncomplicated living donor kidney transplantation. Most of the studies that we had done, in the current study, we had taken only living donor transplants. In all of them, DGF is unusual. So most transplants during the study period were from living donors. But the studies that we use for reference, that is, most of the studies from high-income countries have a high proportion of kidneys from deceased donors. And deceased donors have high incidence of DGF. So they have higher incidence of hyperkalemia because the onset of diuresis is pretty late. But in our study, since we have living donors, we have hypokalemia that is more common. That is why the high incidence of DGF results in hyperkalemia being more common than hypokalemia and a lower risk of developing hypophosphatemia and hypomagnesemia. In addition, our patients with ESRD are undernourished. Generally, Indian population, the patients that come for kidney transplant are undernourished patients. So they have their baseline levels of serum potassium, phosphorus, and magnesium are lower. So they are more higher. Their predisposition to dyselectrolytemia is higher in the postoperative period. So in conclusion, the incidence of dysregulatory leukemia is very high in the first 48 hours of rectal transplantation without a delayed graft function. These are my references, and thank you very much.
My question is it acronyms usually associated with hyperkalemia?
Can you repeat the question?
Is it acronyms that are usually associated with hyperkalemia?
Actually, tacrolimus is more associated with the hyperglycemia that I mentioned. Tacrolimus is an immunosuppressive medication like prednisolone. So that hyperglycemia is the complication that precedes that comes after administration of tacrolimus. That is why hyperglycemia is universal. It is present in all patients. But hyperkalemia is more associated with the diuresis that I had mentioned. The significant diuresis leads to oh, you are talking about hyperkalemia in the foreign studies. I had mentioned how foreign studies have higher incidence of DGF because they have higher their kidney transplantation. Their scenario of kidney transplantation in foreign countries and our setup is different. In our setup, we have more of living donor kidney transplantation, and in living donor kidney transplantation, the concept of delayed graft function, that is, there is not much delay in the graft function getting up to speed. So there is basically less diuresis. Or should I say more diuresis in our setup. But if there is DGF, there won't be diuresis. So there will be accumulation of electrolytes, and that causes hyperkalemia in the studies that we took for reference.
I have a question. What was the precise timing of electrolyte measurement? In the objectives, we have mentioned as 72 hours, but in the conclusion, you have mentioned as 48 hours.
Yeah, that we initially went with the objective of going with 72 hours. Like we took records till 72 hours. But we observed that the incidence of dyselectrolytemia is best documented up to 48 hours because after 48 to 72 hours, the graft function significantly improves.
What time precisely in the 48 hours? Whether it's like the first hour, the 10th hour, or like this
usually, it is the documentation is initially done every 12 hours up to the first day, and then every day up to 48 hours. So after 48%, that is the point. That is why in the table also I have mentioned only up to 48 hours. Because after 48 to 72 hours, since the graft function significantly improves, the serum creatinine also it reaches its peak and comes down after 48 hours. So ultimately it doesn't make a difference in the study. Ultimately, we wanted to assess the perioperative electrolyte abnormality that is present.
Interesting study on renal transplant. So which is the common fluid used pre-operatively and post-operatively in our own hospital?
So replacement fluid is normal strength plus 5% dextrose to its 1. That is post-operatively. So perioperatively we give NS plus dextrose is what I'm aware. I'm not exactly sure. But in foreign countries, the studies we have taken reference for, they also give BSS, balanced salt solution, like plasmolate and RL. But the problem with those is they have higher incidence of hyperkalemia than NS. NS has a high problem of hyperchloremic metabolic acidosis. So different drawbacks for each fluid therapy.
I think this is the last presentation, but I really congratulate all the undergraduate students who have presented so well. I mean, it's very amazing that people are interested in very, your own topic, well about it, well read, gone through it properly. There's no doubt about how you have done your methodology. It was really amazing. I mean, we were just comparing what we did in our life, there was so much. Of course, we didn't have that many opportunities, but great going. I hope others also get encouraged to do this. Congratulations to all of you once again. And thank you for the opportunity to invite.
Okay, so that concludes our session for today. Before we close, I would like to thank each and everyone present here for sparing their time to join us and make this session possible. We congratulate all the presenters and appreciate the time and effort that they have put in producing such quality work on these subjects, potentially opening up promising avenues for future research. So we thank all our esteemed panelists and everyone who has contributed to enriching our discussions today with their valuable insights and inputs. We extend our thanks again to all those who have organized and ensures for the conduct of this session. And finally, we are extremely humbled and express our sincere gratitude to the research committee for having offered us this opportunity to chair this session today. Once again, thank you everyone for your kind attention. One more announcement, we also like to inform everyone that the presentations for junior residents are scheduled to be held here, the same venue, tomorrow at 3 p.m. Please do join us for the same. Thank you and see you.
Thank you, Ms. Chair. We have done an excellent job. Thank you all for being here till the end of this session. So we have refreshments waiting outside for all of us. Thanks, Chair. And I'd like to thank the commentators for this.